find out that sexual function whenever they took the antihypertensive. So it's a challenge for most men, or some men. And also, some are not just comfortable with the fact that they are on synthetic medication for life, because they have this erroneous impression that being on synthetic medication can actually cause some complication at a point in time. So they cannot just believe that. So some of them intermittently would shift to some natural herbal medications just to, find out whether that could be of help. And a lot of them run into trouble as a result of this. So, next slide, please. So, we are very thankful to researchers out there who have found a natural molecule with a difference. This natural molecule is supposed to help regulate and treat hypertension. And what is this natural molecule? It's supposed to be a peptide concentrate derived from protein of fresh cold water Arctic shrimp called Pandalus borealis. And this molecule is 100% natural and from a sustainable source, because out there they do a lot of shrimp farming and they obtain this peptide concentrate from the farm. So the source is sustainable. And it's been proven that this peptide concentrate has an ACE inhibiting effect. So for now, out there, they use it as a food supplement and also use it as an antihypertensive to control mild to moderate hypertension. So all over in Europe, in Canada, this drug is being used. Now, the good thing about this drug is that it doesn't cause hypotension. If you have a normal or if you are pre-hypertensive, you take it, it will not give you hypotension. And if you are hypertensive, mild to moderate, it helps to reduce this, the hypertension. So with all these and the advantages of this molecule and the fact that it's being used in Europe, in Canada, in America, we want to find out whether this drug is effective in blacks. Because you see, for the traditional synthetic ACE inhibitors, we all know that it's supposed to be less effective in blacks as compared to Caucasians. So this drug that is, which is supposed to be a natural molecule, has an ACE inhibiting effect. So we want to find out whether from a natural source, it has an equally effective activity in blacks as compared to Caucasians, or less effective or more effective. So these are the questions we're asking ourselves. So we set to determine the blood pressure lowering effect. Next slide, please. We set to determine the blood pressure lowering effect of PreCardix in 2 different doses. The dose that is used out there is 1.2 grams daily. But then in our setting, we want to these 2 doses and then compare it to lisinopril 10 milligrams and then find out how they all reduce blood pressure in mild to moderate hypertensive patients. And we set out with these objectives to determine, next slide please. We set out to determine the mean blood pressure reduction in mild to moderate hypertensive participants on 1.2 grams of PreCardix, and also to determine the mean blood pressure reduction in mild to moderate hypertensive participants on 1.8 grams of PreCardix, and then to compare the efficacy of these 2 doses of PreCardix with 10 milligrams of lisinopril. The study site, next slide, please. The study site was Kolebu Polyclinic largely, but we have to spread our tentacles to the Kolebu Teaching Hospital main, and thanks to Professor J, who gave us the permission to do that when we were looking for more patients. The approach was a pilot interventional study with a quantitative method of data collection. And study population, we have newly diagnosed patients with high blood pressure. Systolic blood pressure between 140 and 179, and diastolic pressure between 70 to 109. The study design was a longitudinal randomized control trial conducted within 8 weeks. We have 3 arms of the study, tagged red, yellow, green, and balloted to determine participant allocation and sequence. The next slide, please. The red was for 1.8 grams of PreCardix, yellow for 1.2 grams, and green for lisinopril 10 milligrams. The total number of patients we have analyzed was 88. Inclusion criteria, all stable patients, all stable newly diagnosed patients with mild to moderate primary hypertension who have never been on any hypertensive, and patients who the caregiver has determined is safe to manage without the standard antihypertensive, and all patients aged 30 years and above. Next slide, please. We've excluded women, pregnant women with hypertension, those with acute or chronic kidney disease. We've excluded those with thyroiditis, those with stroke, congestive cardiac failure, participants with malignant disease, and also those who are on any natural products targeted at reducing the blood pressure. And then those who are known to be allergic to shrimps or shellfish. Next slide, please. Now, the sampling method we used was a consecutive sampling method, and the primary outcome was high blood pressure control. 3 measurements were taken and recorded, and the mean of the last 2 calculated. Any participant with worsening blood pressure for 2 weeks was withdrawn from the study. And we have 2 participants who had this problem, and we have to withdraw them. We used descriptive and inferential analysis. Inferential analysis, we used repeated measures and over. Ethics, Kolebu Teaching Hospital, RIB, gave us the permission to conduct this study after reviewing our proposal. And also we have the College of Health Sciences Ethics and Protocol Review Committee also went through the proposal and gave us the permission to conduct the study. FDA has already approved the drug as a food supplement to be used in the country. Next slide, please. So our results, the age of patients we have worked on range between 30 to 92 years with a mean and standard deviation, that's 53.2, plus or minus 12.1. Majority of these patients were 60 years plus, 31.4%, and more females were involved, that's 57.9%. BMI range for 17.1 to 54.9, most were overweight, that's 56.3, and about 53.5% had at least SHS education. The baseline mean systolic and diastolic pressures were 146 millimeters of mercury, 164.6 millimeters of mercury, and 104.2 millimeters of mercury, respectively. And the end line mean systolic and diastolic pressures were 134.4 millimeters of mercury and 90.0 millimeters of mercury. Next slide, please. Can I have Thank you. Okay. Yeah, so we looked at the mean systolic blood pressure from week 1 to week 8. after they've been on the drug. So the blue represents the 1.2 grams, and then the orange represents 1.8, and the gray represents the lisinopril 10 milligrams. So analyzing the mean systolic blood pressure from week 1 to week 8, we have seen a constant reduction of blood pressure and at the end of week 8, there's not much difference of the blood pressure, systolic blood pressure measured from this patient after we have calculated the mean. And then, next slide, please. And then we looked at the mean diastolic pressure. So look at this. Those on 1.2, that's the blue, and then the orange 1.8 grams, and then the lisinopril 10, that's gray. And you could see that the reduction is also very gradual to week 8. But when you look at 1.2 grams, it did better than the other two, but not statistically significant though. But that is what you see. Next slide, please. Then we look at the mean systolic pressure drops. We calculated the pressure drops from the baseline. And 1.2 grams treatment. At the end of the 8th week, we have 27.5 millimeters of mercury drop from the baseline. And that of 1.8 grams, 10.4, and lisinopril did 22.9. Next slide, please. And this is how the graph shows it. And you can see that the 1.2 did better. The drop in blood pressure, systolic blood pressure, was constant throughout. And then this is the lisinopril group, and this is the 1.8 grams group. It's very surprising that the higher dose rather is not doing well, but the 1.2 grams rather appears to be more effective as you see it. Next slide, please. So when we analyze this using the repeated measure ANOVA analysis, we realize that the within subject effect was not so within the patient. As we looked at the constant drop over time, over the whole period, was not that significant. It was constant throughout, okay? And then when we look at the in-between, the three groups, that's the 1.2, 1.8, the lisinopril group, that one was not significant. Using the ANOVA analysis, the p-value was 0.17, not significant. Next slide, please. Then we look at the diastolic blood pressures. Next slide, please. This is the diastolic blood pressure, yeah. We also look at the pressure drop from the baseline week after week. And then you realize that at the end of the 8th week, the blood pressure drop from the baseline was 14.4 millimeters of mercury. For 1.8, for 5.2, surprising again. And then for the lisinopril 10, it's 7.3. So the 1.2 appears to be doing better compared to even the higher dose of 1.8 and then the lisinopril. Next slide, please. So looking at the graph, this is how it appears. The 1.2 grams constantly, reduces the drop, reduces the pressure up to week 8. But the lisinopril was not very constant, but then it also reduces, and then we can see the 1.8, how it also behaved. Next slide, please. So, analyzing this, even though it appears to be to be significant. But then when you analyze the within subject effect for the drops, it was not significant. And then in between subject effect, it wasn't also significant. So the drops were constant throughout the period. Next slide, please. So what are the conclusions? So we realized that PreCardix 1.2 and 1.8 appears to be effective in controlling both systolic and diastolic blood pressure, comparable to lisinopril 10 milligrams. And then PreCardix 1.2 appeared to be more efficacious in reducing blood pressure compared to 1.8 grams, making the optimum dose of PreCardix, at least among the patients we have investigated, to be 1.2. The impact of PreCardix 1.2 on hypertension control is not that different when you compare it to lisinopril 10 milligrams. The impact analysis is in your brochure, so you can refer to that. I think that's table 3 or so. So we've come with some recommendations. We need to do larger studies to authenticate the superior efficacy in blast compared to the synthetic ACE we have here. And a larger study is also needed to authenticate the superior efficacy in blast compared to Caucasians. They will soon be presenting the effect in Caucasians, and you realize that what we have here appears to be more effective than, but we need to do a larger study and then try to establish that. A larger study is also needed to investigate the side effects. PreCardix is supposed not to have any side effect, but the sample size we have used is so small, so we couldn't establish that. But I believe that when we do a larger study, it can help us to establish that fact. Yeah. So from what I have presented, this is a drug that will not lower your pressure, even if you take it as a normotesting patient. So if you are struggling with a patient who we do not know whether the pressure was 160, but now is 130, 80, and all that, all the person has to do is to be on PreCardix as a food supplement. And PreCardix will take care of your pressure and bring it to the level that it's supposed to be. If you are a normal person, you take it, it will not bring your blood pressure to a hypotensive level. So that's the good thing about PreCardix. And that's the story I have for you. But let me just, next slide, please. Acknowledge those who helped in drafting the proposal, those who were part of the study and the analysis and all that. So these are the names I have here. Dr. Mensah, is he here, please? Dr. Ajamli, please, can you stand up for them to recognize you? And Dr. Dade, is that Dr. Dade here? No. And Reverend Dr. Tom Dano, can you please? Professor Frank Edwin is not here. Dr. Dazi, is Dr. Dazi here? Okay. Dr. Alfredoku, thank you very much. He's also part of the study. Dr. Francis Ajekum and Dr. Usu Alfredo Ajiman. She was part of the drafting of this proposal. Professor Pratika J was part of helping us in the conduct of the study. And Mr. John Tete, are you there? Yes. These are the statisticians. And then pharmacist Dorcas Boateng, part of the conduct of this study. So thank you all very much for this. So we wait for your questions and we try to answer them. Thank you.
Thank you very much, bro. Is that all that you can do, please? We have our last presentation. All right, and to help us do this is the CEO of Miralis AS, is a person of Andre Semen, who is the CEO of the Norwegian biotech Miralis and is responsible for the commercialization of PreCardix, which is a groundbreaking natural health product with clinically proven blood pressure lowering effect made from byproducts of the prawn industry. Is Andre online, please?
Hello.
Andre, how are you? Can you hear us?
I can hear you fine. Can you hear me?
Yeah, perfect.
Can you see me as well?
We can see you.
Perfect. Fantastic. I see that the host has disabled me from sharing my screen. So if you can allow me to share the screen so I can share my presentation, that would be great.
Very well, they will do that.
So I would need to get that access from someone.
Very well.
Thank you so much. Okay. Hi,
Right.
everyone. Very happy to be here. This is for us a very historic event, as today Ghana becomes the third country in the world after USA and Canada, where we launch our unique and groundbreaking natural health product PreCardix. So by way of introduction first, my name is Andreas Semmingsen. I have had the pleasure of leading the Norwegian biotech company Marialis, who is focusing on creating valuable natural products with specific health benefits from byproducts from the fishery industry. And we are, also, of course, also the company behind PreCardix, bioactive marine peptide concentrate. And I've been asked to give a brief presentation of the background and the story behind Marialis and PreCardix today. So Marialis is a fully owned company by the local Norwegian cornerstone company, Stella Polaris, who is also one of the largest producers and exporters of cooked and peeled cold water prawns in the world. And on this slide, you can see a photo of the factory. This is the factory where we produce the prawns. And this factory and company was actually started by my great-grandfather 55 years ago. And this is also a photo of the village where I personally grew up. The thing about the prawn industry is that the typical raw material that is being fished and underutilized. But back in 2008, we were made aware of a groundbreaking scientific finding done by a researcher from the Norwegian Institution of Fishery and Science, who had found that peptides, so small fragments of protein from the prawn shells, could have a very potent and bioactive blood pressure lowering effect and attributes. From 2008 and the next decade, we worked on a way to produce this naturally, where we extract the protein from the prawn shells and we cut it into smaller specific peptides. And this is done without any artificial additives. We also invested heavily in clinical trials to back up the product attributes. I'll take you through some of those findings and product attributes. So here you can see a photo of PreCardix, the product we're selling. PreCardix is made from proprietary bioactive marine peptides. So we have patented 2 of the most important peptides in this product. What's also important to mention here, a question I get a lot, is if this is all from shrimp shells and it's all naturally, can I not just boil soup from prawn shells and drink this? Or to use a local dish you have as an example, could you eat sheep? Unfortunately, what happens here is that we cut the protein into smaller pieces and get some very specific peptides, which is again causing this blood pressure lowering effect. The product is clinically proven and was peer-reviewed, but in a well-known scientific journal called International Journal of Hypertension. Even though it was done, Mr. Adam and his team in Ghana, they still wanted to do a test on the locals in Ghana, and as we just heard, turns out that the product worked really well in Ghana as well. We're very happy to say that the largest study we did had 89% of the subjects in that trial had a so-called significant medicinal effect. So an effect on blood pressure that is actually going to have an impact on your health. What's also quite unique as a food supplement, what's very rare to document or to even see, is a mechanism of action. So we documented the mechanism of action and found that the peptides in this product is acting as a natural ACE inhibitor. What's also really interesting to see, and what we just learned from the last speaker here, is that the product have comparable effects to some of the most commonly used pharmaceuticals tested on the same baseline populations. Before the trial in Ghana, I should say as a disclaimer that we have not done head-to-head studies, but we've looked at comparable studies done on people with similar baseline blood pressure. The populations we've tested this on has been mild to moderate hypertensive or pre-hypertensives, and has been tested on healthy volunteers without any medication. What we also heard already, and what's been interesting to me to learn about the product, is that we have documented the therapeutic dose. So in our first trial, we tested both a dosing of 600 milligrams and a dosing of 1200 milligrams. We also tested if you take 1200 milligrams daily, but twice a day. And what's really interesting is that does not seem to have a big effect. So you need to take with 1200 milligram dose simultaneously every day to have an optimal effect from the product. What's also quite unique is that we as a company, we will always offer the same product in the marketplace that has been tested in clinical trials. So PreCardix, as we are selling today, will have the same dosing in terms of the medicinal ingredient, the peptides, as has been tested in clinical trials. That is very important to us. Lastly, we also screened for some of the most common seen side effects with ACE inhibitors in the largest trial we did, and we did not see any of these serious side effects. As a specific example, we did not see hypotension, so low blood pressure in any participants. I can also say here as an anecdote is that I've personally been taking the product for 7 years. I've never had high blood pressure, but it's never become low either. So I maintain my blood pressure levels with PreCardix at healthy levels. To summarize how and why we were able to create PreCardix, which is objectively speaking, for me, a very, very innovative and groundbreaking product. We like to talk about the Arctic advantage that we have here. It's pretty cold outside, but we still have some clear benefits up north here. So we are located 70 degrees north. The fishery of the prawns is the furthest activity in the ocean that pharmaceutical marine innovation. So we took advantage of scientists and universities here in Norway to help us develop this product and use their competence in collaboration. We also used our mother company's competence within production and manufacturing. So our mother company have more than 50 years of experience in producing prawns. And we, of course, have a very unique access to the ingredient necessary to develop this product. Stella Polaris, our mother company, they generate more than 5,000 tons of shrimp shells every year. And we have access to all of that to create this product. Then we also have, as I mentioned, a proprietary ingredient that's patented. We also have extensive know-how in just how to produce this product. So it will be very hard for people or other companies to copy this for us. So we're the only company in the world who offer this product, and we're probably going to be that for a while moving forward. Last but not least, there is a big sustainability aspect to this project and to this product. We are leveraging the shell waste from prawn harvesting, and we're thus using an historically speaking underutilized resource to actually help save or help solve one of the biggest health issues in the world in hypertension. So the product itself, bioactive marine peptides, PreCardix, we believe that it's the only clinically proven natural health product for blood pressure health with an ACE inhibiting action without the medical, environmental, or social side effects. I also want to speak a little bit about how or where we position the product typically. So as I've said already, the product is by category, a food supplement or a natural health product or a nutraceutical, depending which country you are in. However, if you look at the product PreCardix versus traditional drugs and medicines, we do not have the same documentation, but we also are a natural alternative. We know that there are hundreds of effective pharma products out there, and most of them are also effective. However, we know that a lot of people, adherence on these medications are low, as we've heard today as well. And we know that a lot of people are searching for natural alternatives. If we move to the supplement side of things, there are not a lot of options out there that actually has clinical validation to it. There's also some questions regarding the ingredients that seem to have some validation, to what degree those are really effective. And then last but not least, the therapeutic dose of the products in the marketplace are often a lot lower in the products that are being sold on the marketplace versus what has been tested in clinical trials. So that is why we believe that we are bridging the gap between traditional supplements and medications. PreCardix is approved, as I mentioned, by FDA Ghana, by FDA US, by Health Canada, and by EFSA for Europe. I can also say that we have a lot of customer stories and in-market data supporting what we've seen in clinical trials, especially from Canada, where we are now, where we now have developed a sustainable business. Last thing I'll say is that our passion is health and sustainability, and we are a certified B Corporation, which means that we are meeting the highest verified standards of social and environmental performance. And the reason why we have that certification, it's a bit complex, but the majority of the reason is because we are using something that has been historically a waste product. We're having a sustainability aspect to it, but we're also helping solve one of the greatest health issues in the world in elevated blood pressure. Thanks a lot. That's what I was planning to say. And again, thanks for having me.
Thank you very much, Andre. So at this juncture, I would like to welcome the rep from the Norwegian Embassy, who is the person of Mr. Robert Hovda. Shall we please invite him?
Good evening, everyone, and thank you very much to the organizers for having me here. It's a pleasure to attend this event, representing the Norwegian Embassy here in Accra. Obviously, I don't have much competence or knowledge about the topics or products being the focus of this lunch, but of course I do understand that hypertension and cardiovascular diseases are a major global health challenge and a major cause of that worldwide. So it's a very important context we are discussing. So, but notwithstanding my ignorance as regards the topic itself, what I can say is that we very much welcome partnerships between Norwegian and Ghanaian companies. Like the one we are witnessing now with this launch. I think that it's fair to say that the private sector and international trade and international investments are key, in a general sense, are absolutely key to sustainable development and poverty reduction, both here in Ghana and globally. So this is also strongly emphasized by the Ghanaian government through its Ghana Beyond Aid vision. And promoting business partnerships between Ghana and Norway has been a core task of the Norwegian Embassy since it was opened here in 2011, 12 years ago. Initially, these efforts were very much concentrated on the petroleum sector, where Norway has a long history and a lot of experience and competence to chair. And also some more traditional seafood exports, not including prawn shells, but that has been a very important part of the trade between our two countries. We now see a broadening of the commercial relations to other areas. It includes waste management, ICT, agricultural equipment, and also some segments of the maritime sector. And I think that Marealis is a very, very welcome addition to this, to the Norwegian companies that have endeavored to try to engage in both Ghana and in Africa in general. And we are also happy to note that Innovation Norway and the Norwegian Research Council have been contributed substantial funding to public funding to the development of PreCardix. We see this as a stamp of quality and appreciation of innovation. It is also, I think, encouraging that the product being launched here today is made from what we normally would consider to be useless waste, discarded prawn shells. But this is contributing to better utilization of our ocean resources. I think both Ghana and Norway are members of the international high-level panel for sustainable ocean economy, which was launched in 2018, demonstrating the importance of that both our countries attached to managing ocean resources sustainably. In fact, today and tomorrow, the Ghanaian government, in partnership with the UN and the Norwegian Embassy, is organizing its National Blue Economy Summit, which is aiming at creating a platform for urgent action to sustainably utilize the vast resources that the ocean provides for Ghana. Ladies and gentlemen, by way of conclusion, just let's say that we wish Marialis and its partners the best of luck with the further engagement in Ghana and in Africa beyond Ghana. I understand that there are also plans to expand to other countries. As already mentioned, we are indeed happy to see new partnerships between Ghanaian and Norwegian companies, and hope that your example can inspire also other businesses in the two countries to follow suit. Thank you very much.
Thank you very much, Robert. So at this juncture, I would like to open the floor. If anybody have a question with respect to PreCardix or the trial done, then we can, take those questions brief. So any question? Any question, please, okay?
Yeah, excellent presentations. And my only question will be the relative costs over the period, if you can know the local cost as compared to the lisinopril and the dose and duration, how much overall it will cost, so that some of us can shift.
Okay, so let me quickly attempt to answer that. Currently, the only pharmacy in Ghana that is a main distributor and it's already available in their retail outlets is AdPharma. Why don't you clap for them? Oh yeah. Yeah. So AdPharma. 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 A very popular name in Ghana. Now, the retail, it's about 3.5? Yeah, per month. 383.5. Yes, please. 383. 50 pesos. No be so. Yeah. That's a retail, not wholesale. Because normally, I've been in the industry long enough. Normally, when you ask for price, they'll give you a wholesale price. You script it, patient gets that, doctor, are you joking? But this is a retail price, and it's already available in all their outlets. So tomorrow, if you issue a script and say, go to AdPharma, you will get it. Are you okay, sir? Thank you very much. Yes. 4 weeks. It's
30 tablets, and you're supposed to take, is it
60? It's 60.
60
It's
tablets
60.
is what I saw.
60 in a pack.
Yes, 2 tablets a day.
Yeah.
So 60 is for a month.
Yes, please.
And so if you have 2 of that, that is for the 8 weeks that was recommended. That's what I'm saying.
8 weeks.
You know, the work was
2
done
months.
for,
Yeah.
yes, for 2 months.
Yes, please.
So that was 8 weeks.
Yes, please.
Okay. Now, I want to find out, because, and that's to Prof.
Prof. Okay.
The first thing was 10 milligram lisinopril.
Yeah.
Was it being compared with the 2002, 2008? Because I realize here that these were newly diagnosed patients.
That's right. Yeah.
Were they on any medication with this as a supplement, or
Yes,
it
so
didn't come out clearly?
they were not on any medication. We've excluded anybody on herbal or whatever targeted at reducing blood pressure. So they were not on any medication that has to do with blood pressure reduction.
But they came in as newly diagnosed hypertensive,
right.
mild to moderate.
Mild to moderate.
And this is being used as a supplement.
Yes, but then
It must come out clearly, because if they were mild to moderate, newly diagnosed
that's right.
hypertensive patients, we would expect them to be on their antihypertensives.
Yes, so that is why there was a proposal, and that proposal was approved. And these patients, when they came to the hospital, and they were diagnosed with a mild to moderate hypertension, they were sent back to their primary physicians. So they actually have to make sure that they can go through this trial without any problem. Okay? there was a drug monitoring group that has to look at the blood pressures over the period. So two patients who were on this PreCardix had their blood pressure going up, and they were quickly withdrawn from the study after 2 weeks. So these were patients who were newly diagnosed, never on any antihypertensives, who were certified to go through the trial safely by the physicians. Okay, and we were also monitoring the blood pressures during the period to be sure that they were not having worsening blood pressure during the period. All right.
Okay, because if you look at the control group here, there was a reduction. And
Control group means lisinopril 10 milligrams.
Yeah.
Yeah.
Lisinopril 10 milligrams.
Yeah.
Lisinopril 10 milligram is not used for treatment of hypertension, so it was just being given. For
No,
the
it was
plaques,
used for
lisinopril
treatment.
10 milligram.
Lisinopril is used for treatment. It's an
10
ACE
milligram.
10 milligrams, yeah. 10 milligrams is used for.
Okay, Prof. So for me, I'm actually very worried because a diagnosis of hypertension, I mean, no matter how mild, now we're looking at diagnosing hypertension with systolic blood pressures of 130 or 80. So if somebody has made a diagnosis of hypertension, then you need drug in addition to lifestyle modification.
Yes.
This product is not, it's a supplement. It's not a drug.
Yes.
So for me, I worry about the ethics of it.
Yes. So
to actually assign people to an intervention which could potentially be harmful. If it's an observational study, that's fine. So for me, I really worry about the ethics of it. We can go back and look at what the ethics people actually approved and if that's what actually happened. But if you make a diagnosis of hypertension in somebody, then they qualify for treatment. Just give me a minute. My other problem is that the results showed clearly from the random fixed effect analysis the impact of the intervention on both systolic and diastolic blood pressure was significantly insignificant over the 8-week period. However, the conclusions don't seem to stem from the results. There's a lot of hedging in the conclusion. So in this pilot intervention study, PreCardix 1,000 to 1,080 appear, what's that?
No.
To be effective. However, the statistics does not support that statement, because when you isolate the intervention effect, and you have stated it nicely that you found an insignificant effect. So why is the conclusion, I mean, not matching the results?
Yes.
For me, that's what I have to say.
That is why I presented these statistics for you to see the effect, the drop in blood pressure values over the period, so that you can appreciate exactly what I'm talking about. But let me go back to the ethics of the study. You see, this medicine, we are not the first people to be using it as an antihypertensive. It could be used as a supplement. That's why I'm saying that it's a wonderful drug. You can take it as a normotensive person. It will not drop your pressure. But then, if you are hypertensive or prehypertensive, it reduces your pressure. Now, we are not trying something that has never been used before. This is a drug that is approved in Europe, in Canada, in America. And they are using it as an antihypertensive as well as food supplement. So we are not trying something in Ghana as a first, as the first people to use it as an antihypertensive, as if you are trying it as an antihypertensive for the first time. No. Otherwise, this will never be approved. The literature on this clearly stated that it has an antihypertensive. That's why they even went into finding the mechanism of action of this drug, which is an ACE inhibiting effect. So the mechanism, that is why we decided to even compare to lisinopril 10 milligrams to see how effective is this one compared with. So the comparison we are doing and all those things saying that it's not significant is because we are looking at its effect and how effective it is compared to lisinopril 10 milligrams. So we are not saying that it's not effective. It is comparable to lisinopril 10 milligrams. And when we look at, if it were more or less, then the effect would be significant in a way. So that is all that we're trying to say. But you wanted to, okay, so you can do that before. This is one of our statisticians.
Doc, you seem right, except that you were not looking at what we are comparing. There's a standard drug which is being used, the lisinopril. How different would this be from the lisinopril, which has already been tested somewhere and being used? How will it operate within the Ghanaian population? That's why we use a pre-test population. Is that okay? A pilot population. But we proved from the study that it is similar in effect of reducing blood pressure to the lisinopril. And our results are even showing, even though it's not significantly different, the drop was slightly better in the PreCardix than the lisinopril, only that statistically it wasn't significant. That's the picture that's being shown. So effectiveness has been established. But compared to a standard drug, how will it perform? And that's what we demonstrate. It performs equally as good as a known standard drug. That's the conclusion we are drawing. Thank you.
Yeah, Prof, I totally understand that, and maybe we can discuss it later on. But from the data here, I haven't seen data beyond what is here. There's only one case study from Canada. I presume there's probably more, because we definitely don't want to base on a single person and what happened. If you look at the within group differences, you can see that there's significant drop within the group. There was a drop in the control group, and there was a drop in the intervention group. However, the between group differences were not different. That is, where I'm going with that. And management of hypertension, 10 milligram lisinopril, I don't think is licensed for that. You understand? And for me, my real big worry is the ethics of it. Because if I see a patient whose blood pressure is 160, I'm not going to prescribe a drug supplement unless I'm not sure. But if I'm sure that this blood pressure is truly 160, then I want to give them a drug rather than a supplement. At least in Ghana, it is licensed as a supplement. It's not licensed as medication. So for me, that is the worrying part. It's prescription. It's not a prescription-only medication. You can go to the counter and get it. And if you look at the case study from Canada, the blood pressure started from 140. So that is, but I mean, no need to belabor the point. But for me, that is the worrying part. I mean, to see my fellow Ghanaian, I know what can happen. I'm sitting there and I am sure. I don't think it's white coat. I'm very sure you have hypertension and it is 160 and I put you on a supplement. Doesn't gel with me. Thank you.
I think Andre have something to share. Andre, can you?
Yes, thank you. Thank you for the questions and the comments so far. I think for me it's very important to highlight one thing. I think it's a very good point that's being brought up here. PreCardix is registered as a supplement. It is registered as a supplement both in Ghana, in North America, and in Europe. So PreCardix is not intended to replace drugs on severe hypertensive people. By no means it's not. However, it's a natural alternative for unmedicated people or for people who are heading towards the danger zone, either through prehypertensive or lower mild hypertensive patients. So again, this is where I think it's important to mention the category we are in. As a supplement, PreCardix has some extraordinary benefits where it's clinically proven to lower blood pressure and have an effect on blood pressure. But if you compare it to well-established pharma products, it's not meant to cure hypertension or to be replacing any drugs. That's not the intention here. Just one comment regarding the trial and the significance of the finding, because in the larger study we did, we had around 200 people, and we had statistically significant results showing that PreCardix actually lowers blood pressure, both systolically and diastolically. And we also had significant results in the ACE inhibition that we talked about. So the data is there, it's published, in addition to this pilot trial that was performed in Ghana, just to replicate the findings and see that it's actually also working on the Ghana population. So hopefully that clarifies a little bit of the ethics behind this.
Okay. Okay. Martin, please. I think the most important thing is the group of patients. Okay, I think it applies to all antihypertensives, because somebody wants to say, like you said, even when you will never use even monotherapy, calcium channel blocker, in that individual alone, you will never use it. So for me, the most important is which group of patients. I always say that medicine is an art. So let's look at which group of patients. If you don't look at that, I think we miss the opportunity to use PreCardix.
Okay, thank you very much. Thank you for the presentations as well. My question goes to Prof. I have 3 questions actually. When I came for this presentation, I was actually thinking about the advantage that this particular drug or supplement will give to us, knowing that some of the side effects, as earlier presenters actually mentioned, with the main hypertensive medications that we know. I was thinking that, okay, so me telling a patient that, okay, I'm taking you off amlodipine as a supplement, and my patient is actually worried about the side effects. I keep my patient on my amlodipine, on my lisinopril, and any other hypertensive, and then I give an added on. Probably you are thinking about the benefit, but I'm also thinking about the financial burden. In addition to the fact that the patient will be experiencing the very side effects that is making the patient non-compliant. So my question is that what do I then tell the patient? That what is this drug actually doing? Is it just trying to reduce your BP, which I think the orthodox medication can actually do it, and they have been doing it if you actually comply to the medication? Or what should I tell the patient? Will it help with the side effects you're experiencing because you are still taking the medication? That's my first question. My second question is, with the trial that you made, you exempted patients that are allergic to shrimps. Should we be concerned about that? If you are allergic to shrimps, does that mean that with most patients that are allergic to shrimps, they're also allergic to other seafoods? Should you be also concerned about these and then try, because in Ghana, we don't have, a lot of people do not even know they are allergic to these things. So should we be concerned about it? And my last question is, when you are taking antihypertensive medications and then your patient stop taking them abruptly, there is a possible rebound hypertension that the patient will experience. I know that for the main orthodox medications that we have. Is there any possibility that patients who have been taking PreCardix and then they stop taking it for one reason or the other, could there be a rebound hypertension? Thank you.
Any other question before Prof and his team? Or Andre?
I can do my best to answer that. So if I'm getting this correctly, the first question is about side effects. And what I can say there is, in the trials we have done, we have not seen any of the most commonly seen side effects with ACE inhibitors or with pharmaceutical drugs. We have not seen significant side effects from the marketplace either. The product has been in the market in Canada now for 3 years. But I think what's also important to mention here is that this is where you as doctors or healthcare professionals comes in, and where also the measuring and monitoring comes in. The first lection here was very good. The best thing you can do to prevent hypertension and to control hypertension is to know your numbers and keep measuring and monitoring your blood pressure. So whatever treatment you're taking, or whether you're adding PreCardix to medication, trying to reduce the amount of medication with PreCardix, or whatever treatment you as doctors recommend to the patient, the most important thing is to keep monitoring and measuring and seeing the results. To what degree is it actually working? In terms of allergic reactions, what I can say here is that technically speaking, the molecule is so small that it's without the so-called allergic potential. However, since it's made from prawns, the human mind is so effective that you can trick yourself into becoming and having an allergic reaction even just by knowing that it's from prawns. Also, from a legal and regulatory standpoint, we have to always advise people with shellfish allergy not to take the product. So that is what we would also recommend you to do. In terms of rebounds of blood pressure, again, this is anecdotal evidence. We did not study long-term effects in the studies we have done. However, what we can see anecdotally from the market is that for some people, the blood pressure stays down for a while, even after stopping taking the product. However, with most people, you have a rebound after a while. If you stop taking it. So as with most medications, PreCardix needs to maintain optimal results. Thank you.
Hello, thank you so much for the presentation, but perhaps I will come from the opposite end of where Dr. Lamptey came from. I will want to know why the choice of lisinopril 10 milligram daily. Because in my experience, however brief, of being a doctor, we do not start patients, newly diagnosed hypertensives on just an ACE inhibitor, because like an earlier speaker alluded to, blacks don't do well on ACE inhibitors, and if you are giving, you're usually giving as an adjunct for renal protection or for the other benefits that they have. And I think that even lisinopril over the period has lost as much credibility as it had when I was in medical school. They are newer, more effective ACE inhibitors that we use now. So why the choice of lisinopril 10 milligram to compare? I will have thought that you should try to do a comparison that we could walk away here with. I mean, the speaker online has said we should use it as, an add-on to the orthodox medicine. But why lisinopril 10? I looked in the brochure and I saw that it is said that it has effective, natural, clinically proven ACE inhibitor properties. So perhaps instead of looking at the effect on blood pressure, maybe you should have looked at what ACE inhibitors are known to do on vital organs in the body. Maybe that is what the comparison should have been. But for blood pressure control, I am not aware that we just do lisinopril 10 milligram for newly diagnosed hypertensives. If you can try to address that for me. Thank you so much.
Okay, let me just try to answer, make a comment on the benefits of PreCardix. I've already mentioned side effects like the coughing associated with ACE inhibitors and the rest. And then also PreCardix as a food supplement. When you take it, you are not likely to experience hypotension. But then if you are pre-hypertensive, it's likely to help you normalize your pressure. And if you have mild to moderate, it helps to also normalize your blood. So taking it as a food supplement and alone can help to either prevent, which I'm not too sure about, but then it can help prevent developing hypertension. The good things about it, I would say that with this, somebody who may be on AC inhibitor alone, who may be coughing with this drug, could be replaced with PreCardix. But I would say that if somebody is on calcium channel blockers, you cannot equate calcium channel blockers with an AC inhibitor, so much so that you want to stop that one and replace it with PreCardix. No. I would say that if somebody has mild hypertension, multimodal hypertension, newly diagnosed, you could try them on it. If they're able to do well with it, then that's it. Then they benefit from the advantages of taking it without any side effect and all the other things. So there's no need to now try to take somebody off the regular antihypertensive and substitute it with this one. No, I don't think that is wise. But if the person is reacting to AC inhibitor and you know that you have something that you can substitute for it with no such side effects, then you can do that. It's an advantage. Now, about the choice of lisinopril 10, we choose that not because we think it can help us in a way, but then we need to compare it with a standard antihypertensive already in the market that has an AC inhibiting effect. So that is the reason for the choice of lisinopril. And we just want to do a comparison and to see how the drug behaves in comparison with lisinopril. And that is what we've got. So whatever interpretation we give to it, if lisinopril is no more used as an antihypertensive and is no more effective, but that is what we've got. I would not say that this is an invented or cooked values. These are values that we got from patients who have been on these three arms of medication. And this is what we've got. Some have not had their blood pressure reduced to the level that we wanted. But when you look at the mean, it gave us some hope that this drug may be beneficial in some patients. So we can take advantage of that. That is all that we are trying to say. And we are not trying to say that stop all your antibiotics and shift your patient to PreCardix. No. As it was rightly said, PreCardix is a food supplement, but it has antihypertensive properties. And you can latch on that advantage and help some patients who may not need too many of these antihypertensives to have their blood pressure control. That is all the message we are trying to bring across. Thank you.
MC, please can we get ready and launch the medication so that we can go and do other things?
Last question. Okay, so from the chairman is using his authority to veto everything. So thank you very much, Mr. Chairman. I need to learn to take instruction. Very, very important. So to launch PreCardix, ladies and gentlemen, I would like to invite our chairperson, Professor Patrick J, and then the officials of Miralis Africa. Where is Dr. Smith? Yeah, Dr. Smith. Dennis, please.
Thank you very much. I think we are ready to talk about PreCardix. I think at the beginning I said the future of medicine is here. Food as medicine. That's where we are going. We are not talking about all the pills. Medicine is not an exact science. So we shouldn't keep on focusing on ACE-like effect, thiazide-like effect, and thiazide drugs. Most important thing I want to share with you before we launch is Mucuna pruriens. It's a wild plant that grows all over the place. So when you're going to Akosombo, just after Atimpoku or that place where those funny shrimps are, those funny fishes, the little ones that they sell. Yeah, on the left and right of the road, you see this funny tree. It's, plant, shrubs. When you dry it and make a powder out of it, it also has levodopa-like effects. And we've used it to treat our Parkinson's. But the good thing is, food as what? Medicine is the future. We don't stop our anti-Parkinson's. Levodopa is a supplement, so we add it to it. And the beautiful thing is it prolongs the levodopa-induced side effects in Parkinson's. So that's where we are going. Food as what? Medicines. Thiazide-like medicines. And ACE inhibitory effect. So nobody should stop any ACE. So we shouldn't think of stopping ACE when we have a case of hypertension, but as a supplement. And I bet you most of your patients will love to take these food as medicines, as a supplement to improve their to improve their hypertension against increasing the doses from 20 to 40 and or adding on other medications. So let us look at the beauty of medicine. Medicine is never of additions and subtractions and divisions, which depends on the numbers involved. So the higher the number, the higher the output, and the better the results. And we call that a very powered study. Let us end it here and let us launch this drug. And then we'll talk about food as what? Medicine. So where's the CEO? May you come and stand here. MC, come and continue the thing and pull the thing and let's launch the medication. Don't light the thing yet. Should I cut it? No prayer. It's okay, according to MC, he's a reverend. So we all standing here declare this drug officially launched. It's approved as a supplement by the Ghana FDA, so nobody should stop any ACE or ARB. Thank you. Oh, wait. You want to come and light us or burn us? Now you can light. Let me stand here.